Dear students, today we will continue to study our subject called physiology, and today our fourth lection it called Cavernous pulmonary tuberculosis, fibrous cavernous pulmonary tuberculosis, and cirrhotic tuberculosis. It is our lecture plan. Cavernous tuberculosis. It is characterized by presence of an elastic cavity without perifocal inflammation and without foci. Occurs asymptomatically. Occurs asymptomatically. A cavern is pathological cavity bounded by a three-layer capsula, the inner layer of which consists non-rejected caseous masses. The middle layer is layer-specific granulation, and outer layer is a fibrous layer. Pathogenesis and sign of caverns. In this slide you can see the fresh decay, elastic cavity, and fibrous cavity. Complaints of a patient is weakness, loss of appetite, chest pain, night sweats, increase in body temperature. Differential diagnosis must be done with abscess, a cavity with pyogenic capsula, lung cyst, beiged pneumopleurisy, limited pneumothorax, bullous emphysema, bronchoectasis, lung cancer, etc. Treatment in the intensive phase for 2 months, a combination of 4 anti-tuberculosis drugs, then in the maintenance phase for 4 months with 2 drugs. In case of ineffectiveness of therapeutic treatment, surgical treatment is used. Types of healing of cavities. First one is scar, perforation of scar. Second one is hairs. Third one is blocked cavity and pseudocyst. In this slide, in upper lobe of the right lung, you can see the elastic cavity. Fibrous cavernous pulmonary tuberculosis is formed as the result of an unfavorable course of destructive tuberculosis process. It is main features old fibrous cavity, fibrostic in adjacent lung tissue, bronchogenic dissemination, lung scars with period of excubation and remission, period or constant bacterial excretion. Clinic. Sick indicate a long course of the disease in which period of exacerbation with severe intoxication and replaced by periods of relative improvement, even restorative working capacity. The intervals between this period are quite long, but gradually the periods of remission are reduced, pulmonary and cardiopulmonary insufficiency increase. Here are the several variants of fibrous cavernous lung tuberculosis. It is limited fibrous cavernous pulmonary tuberculosis with a stable course. It is progressive course and flow with complications. In this slide you can see in the upper lobe of left lung you can see big and fibrous caverna, and schematically you can see also this caverna. Gigant fibrous cavity in the right lung. In the upper lobe of right lung you can see gigant fibrous cavity. In this slide you also can see, I will show you the gigant cavern. Here it is, the gigant cavern, and here also has the caverna. It is pathomorphological how it is look like caverna, and it is his wall consists of 3 layers. It is also schematically process of fibrous cavernous tuberculosis. You can see the fibrous caverna and daughter caverna. We called it daughter caverna. Additionally, caverna in the low part of left lung. Differential diagnosis in the structured forms of pulmonary tuberculosis studies that need to be carried out in case of suspected tuberculosis with the detection of decay cavities in the lungs, multiply bacterioscopic and bacteriological examination of sputum, cytological examination of sputum, tomography, bronchoscopy with taking material for cytological and histological analysis, puncture or biopsy of the peripheral lymph node, with it increase. Air test, it is differential diagnosis. You can see the air test in the upper lobe. I will show you. Here it is. And in the tomography you also can see the air test. Chronic abscess, it is also one form of such disease that look like a fibrous cavernous tuberculosis, and in the scheme you can see the abscess and the level of liquid lateral radiography, and in help of this level of liquid we can tell that it is chronic abscess of lung. Cancer of right lung, it is also look like fibrous cavernous tuberculosis, and our help to make right diagnosis, CT, computer tomography. It is also the lung cancer. Cirrhotic tuberculosis. Cirrhotic pulmonary tuberculosis is characterized by a massive proliferation of coarse connective tissue in the lung and pleura as a result of involution of various clinical forms of pulmonary tuberculosis or specific pleurisy. Pleura pneumosclerosis is a diffuse proliferation of connective tissue in interstitium while maintains its structure, and pneumatization with loss of elasticity. Fibrosis changes of or lineal or focal-like form, limited prevalence with loss of elasticity of affected area in the lungs. Cirrhosis is characterized by a massive proliferation of connective tissue with a gross violation of the structure of the lung and its pneumatization. Cirrhosis can affect severe segment, a lobe, or even the entire lung. In this slide you can see the cirrhosis of upper lobe of right lung, and you can see the increase of volume of this lobe. By pathogenesis, cirrhotic pulmonary tuberculosis can be pneumogen, bronchogen, and pleuragen. According to pathological sign, it may be local, unilateral of bilateral, segmental, lobar of total, or diffuse bilateral after disseminated tuberculosis. Cirrhotic tuberculosis with a limited damage to the lung tissue, as a rule the upper two segment, with deformation, absence of cavity. Such patients as a rule feel well, nothing bothers them. Such patients do not have clinical manifestation of relapse of years, decades. Such patients are epidemiologically dangerous if they are all the more than family, but secret mycobacteria in small quantities. In some cases, this form against the background of acute respiratory infection or stress, often being recur. The patient begins to have a fever when cirrhotic tuberculosis with frequent relapse. The patient begins to have a fever usually subfebrile. Intoxication syndrome manifests itself, which is most often manifested by the fact the patient loses weight. The patient quickly becomes dehydrating, loses weight, and process due to frequent recurrence begin to progress, and fibrous tissue capture half of the lung or of whole the lung. Often the second lung is affected due to bronchogenic seeding. Inevitably, bronchoectasis is formed without fail. Cirrhotic tuberculosis with bronchoectasis. These patients are severe, sometimes evident bacterial excretion. Up to 1 liter of sputum can be excreted per day. The patient is emaciated, has a high fever. Such patients are extremely severe. Bronchoectasis is extensive, secondarily unaffected, and very difficult to treat. In this case, surgical methods of treatment cannot be applied with these patients are doomed. Cirrhotic tuberculosis destroyed lung or lungs. This is formed in the process of a long constant progression of the process with the development of fibrous tissue. In this case, pulmonary heart failure is observed. However, anasarca with such cardiopulmonary insufficiency is practically not observed, since these patients are constantly feverish and fever always leads to dehydration. Therefore, in the treatment of such patients, it is necessary to carry out infusion therapy. X-ray. During the X-ray we can see blackout, but not all homogeneous. Against the background of darkening cellular enlightenments, lungs field on the effect side are sharply narrowed. The root of the lungs are pulled up. Pulmonary drawing below thoracical area is deformed. The shade of lungs vesicle trunk extending from the lower part to the root equivertation direction. Trachea, mediastinal organs are displaced to side of the feet. The diaphragm of affected site is pulled up. Its contours are uneven. On the opposite side, the pulmonary patterns is also deformed. The roots are compacted. The lungs field may have increased transpersonally and include isolaceous patchy shadows. In the rentgenological picture, you can see bilateral cirrhotic pulmonary tuberculosis. It is X-ray and X-chem. Pleurogenic cirrhosis of left lung. You can see the development of cirrhosis after pleurisy, dry pleurisy very often, in the left side. Differential diagnosis. Cirrhotic pulmonary tuberculosis must be differential from inactive post-tuberculosis cirrhosis. A decisive long-term dispensary observation is important, confirming the stability of process are absent of excalibration and tuberculosis and sustainable bacteriality with multiply sputum culture. Treatment. Most often limited to the use of symptomatic agents with bacilli excretion combined antibacterial drug, taking into account sensitivity, periodically to prevent exacerbation of tuberculosis. Prophylactic course of an antibacterial treatment are carried out with limited cirrhotic change surgical treatment. It is literature which was used to prepare this lecture, and thank you for your attention. If any question, you can write to our email tizyatriakimi@mail.ru. Thank you for your attention. See you soon in our fifth and last lecture.